Listen-only mode.
Good afternoon. Thank you for joining today's webinar titled Medicaid Redesign and Implementation of Mandatory Managed Long-Term Care. This is second in a series of webinars provided by our association on the topic of Medicaid redesign. I am Laura Cameron, Executive Director of the New York State Association of Area Agencies on Aging, and I will facilitate today's session. Our presenter, Mark Kissinger, will provide information on the status of Medicaid redesign with a focus on the implementation of a mandatory program for dual eligibles who require community-based long-term care. Today's presentation will be recorded and will be available to webinar participants at a later date, along with a copy of the PowerPoint. We are planning a series of webinars of Medicaid redesign. Information will be posted to our website. We do welcome feedback. You will receive an electronic survey at the end of this session. Before we hear from Mark Kissinger and Greg Olson, here are a few webinar basics. The first thing to note that all attendees will be muted. You will not be part of the audio feed. You will only hear from our presenter, Greg, and myself as facilitator. In order to listen, there are two ways to hear the audio, either by telephone or microphone speaker. The webinar is scheduled for 1.5 hours. At the end of the presentation, there will be an opportunity to ask questions. To ask a question, type your question into the question box in the upper right-hand side of your screen. When you think of a question, please type it into the box right away. I will review all questions during the presentation and will ask the questions at the end on your behalf during the Q&A segment. I am now pleased to introduce Greg Olson, Acting Director of the New York State Office for the Aging, who will provide opening remarks and will introduce Mark Kissinger. All of us in the Aging Services Network extend our appreciation to Greg for his leadership in the field of aging during this time of systems change. Welcome, Greg.
Well, thank you, Laura, and I want to thank Laura Cameron and Karen Thornton, and especially the New York State Association of Area Agencies on Aging for hosting this webinar today. And also a special thanks to Mark Kissinger for joining us. As many of you know, there are a lot of changes going on in New York State and how we're delivering health care and long-term care. As you also know, the state has organized the MRT, the Medicaid Redesign Team, to provide opportunities for the public and others to recommend changes to Medicaid to make the program work better, cost less, and improve outcomes. The MRT has also had a managed long-term care implementation and waiver design work group, and a decision has been made to expand care coordination models such as mandatory managed long-term care. These changes are very important for the area agencies and their subcontractors to know and to understand what opportunities exist both today and into the future in working with managed long-term care organizations. I know that there have been a lot of questions that the area agencies have had. There are a lot of moving parts and pieces, and fortunately are joined today with the right person who can answer those questions, bring us up to speed, provide us with not only what's happening today, but a roadmap to the future, and certainly at the end answer some of the questions that many of you have posed to me and to the Department of Health as well. So to talk to us about managed long-term care, I really have the distinct pleasure of introducing our friend Mark Kissinger. Mark Kissinger is the Director of the Division of Long-Term Care for the New York State Department of Health's Office of Health Insurance Programs. Prior to this appointment, Mark, who lives in Del Mar, New York with his wife and 2 children, served as the President of the Home Care Association of New York State and as Deputy Secretary for Health and Human Services, where he was the lead policy advisor on health and human services issues, including Medicaid, mental health services, long-term care, welfare, and children's services. During his career, Mark's assignments have included Senior Program Associate for both the New York State Governor's Office, the New York State Senate Majority Leader's Office, and the Deputy Commissioner for the Office of Long-Term Care. Mark earned a Bachelor's of Arts degree from the University of Michigan in Political Science and has won many awards for his leadership and commitment within the human services field. On a personal note, we work very, very closely with Mark. He has been a tremendous asset and friend, not only to the State Office for the Aging, but to the Aging Network as a whole. And we look forward to our continued work with him as we try to make sense and understand a little bit better the synergies and the systems integration work that we can be continuing to do together to bring the network of the Aging Network and the long-term care networks together to really serve individuals from a holistic perspective and ensure that the goals of the state in terms of quality outcomes, measurable successes, and lower costs can be realized. So, Mark, thank you for joining us today and look forward to your presentation.
Thank you, Greg, and thank you, Laura, and the association for having me here today. I just want to lead my presentation saying I started my career in aging. Right out of college, I was working on the Senate Aging Committee and have known Laura for a long time, as well as Greg, and they're true advocates and friends of the elderly. So I'm here to talk a little bit about Medicaid redesign and implementation of the Mandatory Managed Long-Term Care Initiative. So Medicaid redesign, if you've seen it on the, if you heard about it, it's been in the news in healthcare for the last year since Governor Cuomo took office. And there actually is a plan to transform Empire State's Medicaid program that just got released by the governor's office and up on the DOH's website. And I would strongly suggest that everyone take a look at this plan. It is kind of the roadmap that the Department of Health and the Office of Health Insurance Programs are using to really transform Medicaid in the future. This is a big ship. The Medicaid is a big ship, and we are trying to turn that ship and also at the same time while running this $53 billion enterprise. So part of the multi-year Medicaid redesign team action plan is what's called Care Management for All. If you look at page 9 of that plan, the MRT really set up on a multi-year path that every single Medicaid recipient should be in some sort of managed care or care management. That's about 5 million people should be moved towards care management or managed care. A big part of that are people that use Medicaid for their long-term care services. And in last year's final state budget, the legislature and governor agreed to a plan to move persons in need of community-based long-term care services into what's called mandatory managed long-term care, and that's what we'll talk about a little bit more today. So first, what is managed long-term care, and what are the goals of managed long-term care? The major goal is to give one entity responsible for assessing and arranging all levels of care, and that is done to improve the outcomes for the enrollees, prevent or delay decline due to chronic conditions, reduce the need for hospitalizations or acute care services, improve satisfaction with the life status for enrollees and their caregivers, and I stress caregivers, it's a big part of the aging network or the long-term care network, and obviously produce savings for payers. When we talk about producing savings, we really talk about reducing the cost rate of growth. The term that people use now is bending the cost curve. So it's not necessary that 1 year we'll spend $50,000 on a person, the next year we'll spend $49,000, but it's really, I use the example of 1 year we'd spend $50,000 on a person, the next year we'll only spend $50,500 instead of $60,000 or $70,000 Medicaid dollars on that person. So it's really producing savings is cutting the rate of growth in costs for persons on Medicaid in need of long-term care. What is a managed long-term care plan? So if you go to Public Health Law 4403F, it outlines the statutory scheme for a managed long-term care plan. It was a law that was passed back in 1997. I was in the Senate then and got to work on it from the legislative side. And it was an agreement between the Senate Assembly and the governor's office to try this demonstration program to move people into managed long-term care plans. At that point, we're all worried that we're going to have a mass of people enrolling into one plan. So we enacted a cap on the plan of no one plan could have more than 50,000 members. Now today, 2012, roughly we have about 50,000 members in the voluntary program right now. So I think we wildly overestimated what we thought the success would be of the program would be back in 1997. Excuse me, but we have a voluntary managed long-term care program mostly operated out in New York City with managed long-term care plan providers that are both insurers and providers. So in order to be a managed long-term care plan, you have to have a certificate of authority under Article 44 of the Public Health Law to meet the member needs for health and long-term care and to receive capitated payments for benefit package services on a per member per month basis. So it's really moving from a fee-for-service to a capitated approach. The population, the general target population is adults age 18 or older, eligible for nursing home level of care using the semi-annual assessment of member needs, or the SAM assessment. That assessment tool will be changing to the uniform assessment system in the future. Able to live safely in the community upon enrollment. So we can't enroll people that are already in institutions in managed long-term care. And in need of long-term care services planned for at least 120 days. Now, long-term care services could be nursing, therapy, or aid services in the home, adult daycare, social daycare if used as a substitute for personal care. So long-term care services is kind of a broader definition from the Medicaid terms. You also, to be in the managed long-term care plan, you cannot be concurrently enrolled in a home community-based service waiver program. And those major waiver programs are the long-term home health care program, or a Lombardi program as people know it, the nursing home transition diversion program, or the TBI waiver program, or the OMRDD day treatment program, or hospice at the time of MLTC enrollment. So you have to choose managed long-term care or one of these waiver programs in the current environment. And you can be enrolled in the Medicare Advantage plan concurrently, but not in Medicaid managed care. So you can be in managed care on the Medicare side, but concurrently you cannot be in Medicaid managed care and be in managed long-term care at the same time under current rules. Managed long-term care is a rubric for 3 different major models. Partially capitated managed long-term care is the prominent model. The program for all-inclusive care for the elderly, or PACE, is another part of a program under managed long-term care. And then the MAP program, a Medicaid Advantage Plus. Those are the 3 models, and I'll go through those 3 models. So partially capitated means that they're capitated for some, not all, of Medicaid services. The benefit package is long-term care and ancillary services, including home care and unlimited nursing home care. Primary and acute care are covered by fee-for-service Medicare or Medicaid. Right now, there's about 14 plans that offer this product, as I said, mostly down in the New York City area. In April of 2012, the enrollment was a little bit over 45,000, and that we see a big spike in that enrollment in the last 3 months, and it's increasing every day. And these programs vary in size, with the smallest program being a little bit over 100 people, the largest program being over 10,000 people. So they vary in size. Now, the department had a moratorium on the development of or expansion of partially capitated plans between 2006 and 2011. That moratorium was placed on partially capitated plans because we wanted to move all the plans towards full integration. I'll talk about that a little bit later. So here's the partial capitation benefit package. Medically necessary services including care management, home care, unlimited nursing home care, personal emergency response system services, OT, PT, speech therapies, both in-home and outpatient, medical and social daycare, dental, optometry, podiatry, audiology, transportation, DME, social and environmental supports, and the plan pays for Medicare cost sharing on nursing home DME and outpatient therapies. So it's not the full Medicaid benefit package, but it's a pretty substantial one on the long-term care side. The next model of managed long-term care is called the PACE model, and that's based on, actually if you go back, that's based on a demonstration program out in San Francisco. It's a national model which is federally regulated with a very involved federal statute. So it's a federal program type. It's both Medicare and Medicaid at state option. It's capitated for all Medicare and Medicaid services as opposed to just some Medicare services. And it's the most integrated of all the managed long-term care models at this point. It's based, the PACE model is a day center, clinic-based model. So you have to have a day center or clinic as part of that model if you want to operate a PACE. The provider network is usually small. That's one of the detriments of the PACE program is the providers. It's a pretty closed provider network. But the benefit package is all medically necessary services, primary, acute, and long-term care. 8 plans now offer this product, and the April 2012 enrollment is 4,300 people, and they range from a program size of 81 to a program size of 3,000. So that 3,000 program is, I think, one of the largest programs in the country. We have an extensive PACE network here in this state. Beth Abraham's PACE is the largest PACE program in the country. So the state has a long history of evolving PACE enrollment. And no one new PACE program is under development. There's talks of a lot of other PACE programs in the works, but we know of only one new PACE program under development. Here's the benefit package. I won't read the slide to you, but you see it's both long-term care and acute care, including inpatient hospital and physician services. The next type of managed long-term care is called Medicaid Advantage Plus, or MAP. It is capitated for both Medicare and Medicaid under 2 separate contracts, a federal contract and a state contract. All plans must cover the combined Medicare and Medicaid benefit package as defined by the Department of Health, and plans must meet both the Medicare and Medicaid requirements. The challenge of this plan is to have this appear seamless to the member. So all this stuff is happening in the back office in the coordination of benefits between Medicare and Medicaid, but to the member it's really a seamless type product. We now have 8 plans that offer this product, and enrollment is very low at 1,875 people as of the April 12 census. Again, we have the range of plans from a really small plan of 45 to a larger plan of 633. So this is a very small plan, very small program that when looked at the PACE and/or the partially capitated programs. So the Medicaid Advantage benefit package is basically all Medicare services, and then all Medicaid services with the exception of some specialized mental health services. So it's basically everything in Medicare and Medicaid. So let me go back talk a little bit about the big changes in long-term care that were enacted as part of last year's the 2011-2012 budget in the MRT process. So as I said, the goal of the Coleman administration is to move everyone into managed care or care management. We call it the Care Management for All goal. And in last year's budget, the legislature passed, the governor proposed and the legislature passed legislation requires that all dual eligibles, so both eligible for Medicare and Medicaid, who are 21 and older and in need of community-based long-term care services for more than 120 days, must enroll in a managed long-term care plan or a care coordination model. So basically we said if you want to get long-term care services through Medicaid in the state, you have to get them through managed long-term care or care coordination models. The duals between 18 and 21 remain in the voluntary category, but the vast majority of people in need of long-term care are 21 and over. So that is a fundamental change to how long-term care is organized and financed in this state. I often wonder if when the legislature passed that law, everyone really understood the implications of that change. But here we are, trying to get federal approval on that law and going towards implementation. So we need a approval from the Center for Medicare and Medicaid Services, CMS, before we can go live. So the vehicle that we use to get approval for things such as this is an 1115 Medicaid waiver, which is a research and demonstration waiver. We have a very extensive Medicaid waiver right now with the federal government. We have 2 major waivers, and this would be an amendment to our current waiver. So the populations that were there prior exempt from the managed long-term care move are being moved into through the 1115 waiver. And also, we eliminated the need to score as a nursing home eligible for enrollment. So where the nursing home eligibility test was there, this law and this waiver will eliminate that need to score as nursing home eligible. Now, what is community-based long-term care services? What does the legislature mean when they pass this law? So our definition of community-based long-term care services on the Medicaid side is personal care, home health care, adult day health care, and private duty nursing. Those are the 4 big buckets of community-based long-term care services. In addition, the legislature passed what's called the care coordination models, and we had to, by November of last year, we had to put out guidelines for the definition of what a care coordination model was. So the guidelines must address requirements in 4403 F3A1, which is a very technical statutory reference, but really is that it meets the same general terms of the managed long-term care plan, and that the payment methods that evolved would ensure provider accountability for cost-effective quality outcomes. So in the legislation, it included the long-term home health care program, said that basically we had to consider the long-term home health care program when we did the guidelines. And we convened a Medicaid redesign team work group, which Greg mentioned in his intro. We worked all summer and fall to develop the principles for this implementation, and then that would apply to care coordination models. The guidelines that incorporate those principles were posted on the DOH website right by the deadline on November 15th, and they can be found on the link that's found below. And as an aside, we often encourage people to go to the Medicaid redesign team website as often as possible, because that is our vehicle for communicating major changes in the program. So what's happening this year as far as mandatory enrollment? We made a decision as a state to start with New York City, and the target date for that start is July 2nd, 2012, which is fast approaching. We still do not have federal approval at this moment for this waiver change, although we are getting very close to federal approval. So it's all systems go at this point. So what does it mean for people who need long-term care services, both newly eligibles and also people who are in those 4 long-term care service types? Right now we're working with HRA, the Human Resources Administration in the city, to determine the most effective, efficient way to transition people. We decided, and working with our city partners as well as with the feds, that we're not going to, this will not take place all at once. We are going to start by program and by borough, and actually by zip code, into transition people that are already in care, in the personal care program first, into managed long-term care choices. The consumer has a choice of plan. The legal authority we got last year allows us to auto-assign people for people who do not make a choice. That's the mandatory aspect of the program. So obviously we would hope that the consumer and their caregiver makes a choice of plan, and we don't have to use the auto-assignment, but we do have the ability to auto-assign people into plans. So the key is we must ensure continuity of care and a service provider. We've asked all the plans to send us their continuity of care plans and service provider networks, obviously in anticipation of this move. And as soon as we get federal approval, we're going to be ongoing a significant education component for people new to the system and for the people transitioning. So let me just say it more clearly. So if persons are in need of long-term care services in the community after July 2nd in Manhattan, in New York City, the only way they can get those services is, and they're 21 and over, is through plan. It's not through the fee-for-service Medicaid program, which is a huge change to the way we've been doing Medicaid for a long time. And then for persons that are already in the personal care program, we're going to transition approximately 2,000 a month, or the real goal is 24,000 of those participants by March 31. So for people in the receiving consumer-directed personal care services, we've delayed that start date until September of 2012. So that start date will be 3 months delayed from the July 1 start date. So we're going to start with the agency-directed personal care program in Manhattan, July 2nd. Now, several groups are not eligible to enroll in managed long-term care until the way the law reads, program features and reimbursement rates are developed for those people in those programs. And there are really 4 major buckets of people who will not be eligible to enroll in managed long-term care. Persons that are in the traumatic brain injury waiver, the TBI waiver, persons who are in the nursing home transition diversion waiver, persons in the Medicaid-funded assisted living program, or ALP, and persons in the Office of People with Developmental Disabilities, or OPWD waiver. Those persons are excluded from this initiative in last year's budget. It's right; these exclusions are right in the state law. So once we go outside of New York City, it becomes a little bit more tricky, because we need to have choice of plan or plan capacity in all areas of the state. We clearly have choice of plan in the city and the suburbs of New York, but we have some work to do on developing managed long-term care or care coordination model capacity outside of the city of New York. The federal standard is that there must be a choice of 2 plans in urban areas and at least 1 plan in rural areas. That's the federal minimum standard. Obviously, we're going to try to get more choices for people, so they have at least a choice of 1 or 2 or maybe hopefully 3 or 4 managed long-term care plans to choose from. As I said, we have work to do on expanding capacity outside of New York City. And what we'll do is, as we expand capacity of plan, we will then bring additional counties into this rollout. Like on the mainstream healthcare managed care side, additional counties will roll in as we develop MLTC and CCM model capacity. So as I said, we have capacity in the city and the downstate suburbs, Nassau, Suffolk, Westchester. We are working on capacity in other areas of the state as we speak. So how does one become a managed long-term care plan? Right, the new law that was passed last year eliminates the requirement that they had to be designated by the Senate, Assembly, or Commissioner. So really, it's an open enrollment process for one to become a plan, and the applications for new entities or new lines of business and expansions are on the DOH website. The link is on the slide before you. So in order to become a managed long-term care plan, it's a significant undertaking. You require an adequate legal structure. You have to identify the service area and target population, including any special populations. You must undergo a character and competence review at the health department, a contracted network review. You must describe to us, to our satisfaction, of the care management model as well as a grievance system. And then you must demonstrate financial capability and capitalization. Since you are taking risk for Medicaid benefits and sometimes also Medicare benefits, you need to demonstrate that you're a plan that's able to take that risk and have the financial capability and capitalization required to do that. So the statute allows up to 75 MLTC certificates of authority. 42 new certificates of authority are available for new MLTCs can be approved. We have the difference already approved. And then applicants approved for a certificate of authority will enter into contract with the department, and a readiness review is conducted before operations begin. So I have a small staff that does just application, MLTC application reviews, and they review them for character and competence, financial feasibility, and other elements as required by the federal Medicaid and Medicare laws. So here's the actual enrollment plan. Again, I'll go through, you'll see some duplication on this slide, but let me go through exactly how we're going to roll this thing out once we get federal approval. It's, again, duly eligible, Medicare and Medicaid, age 21 and over, receiving community-based long-term care services for 120 days, excluding the following for now: NHCD, TBI, persons in nursing homes also will be excluded for now, assisted living program participants, and then the duals that do not require community-based long-term care services will not be in the rollout plan. In addition, those who must enroll in managed long-term care or CCM model, the following people may enroll, may voluntarily enroll: duals that are 18 to 21 in need of community-based long-term care services, dual eligibles 18 to 21, and non-dual eligibles 18 or over, assessed as nursing home eligible. So basically, we're trying to, as I said, the overall approach is to move to care management for all. There's certain populations which must enroll, and then there's certain other populations which will move on a voluntary basis, and ultimately will move people into care management programs. So phase 1 is beginning in July 2nd. Actually, the first is a Sunday. So it's beginning July 2nd. Any new dual eligible, new to service, fitting the mandatory definition, any of the New York City County will be identified for enrollment and referred to the enrollment broker for action. So if you're new to service, something happens and you need long-term care services, the way you get that is through picking a plan. The enrollment broker will provide educational material, list of plans, or CCMs, answer questions, and provide assistance to contract your plan if requested. So the enrollment broker is kind of the fulcrum upon which people get the information and work with their caregivers to make choices. The plan will conduct an assessment to determine if the person is eligible for community-based long-term care, and then the plan transmits enrollment to the enrollment broker. So that's the new people to service. It's kind of the front door population, we call it. The people that are already in service, we're going to roll out through the city and then upstate. So the enrollment will be done phased in batches by borough and by service type. People will be given 60 days to choose a plan according to the following schedule. In July, we're going to begin with one zip code, actually, in July in New York County, in Manhattan. And then we will roll out in August, more people in Manhattan. And then in September, we're going to roll out more people in Manhattan and begin also the Bronx, and begin consumer-directed cases in New York, Manhattan, and the Bronx. October, we will continue with Manhattan and the Bronx and then add Kings County. So we're kind of rolling through the city of New York. November, we're going to continue with the New York, Bronx, and Kings counties. And then in December, we're going to add, Queens and Richmond counties as well. So we're going to actually go through the city on the personal care side in this calendar year. January 2013, another big milestone in this enrollment plan is we're going to initiate enrollment citywide of persons currently in the long-term home health care program, persons in receipt of home health care services over 120 days, adult day health program participants, and private duty nursing cases not already enrolled under the personal care activity. So really the personal care is this calendar year, and then we'll move in 13 to the other buckets of people in need of home and community-based care over 120 days. And in February, we'll keep going with basically all the populations. Individuals receiving personal care while enrolled in Medicaid Advantage will begin enrollment in 2013. That's a small population, but it's footnoted there for you. So we're kind of moving through the city, through the population, and through the bureaus and through the different programs. And then that's really phase one. Phase two, so we'll get through the city, hopefully, in that phase one environment. And then phase two will start in June 2013 as well, and we'll enroll. We have managed long-term care capacity in Nassau, Suffolk, and Westchester County, and we anticipate to start those populations in January of 2013. Phase 3 would be Rockland and Orange in 2013, June of 2013. Then we'll go upstate urban, so Albany, Erie, Onondaga, and Monroe in December of 2013. And then in 2014, we're going to do counties as we have managed long-term care capacity. So really, for a lot of the upstate counties, you're not going to see this until in 2014. Then obviously, as I mentioned before, the previously excluded dual eligible groups will be contingent upon developing appropriate placements, but our goal is to move everyone into care management. So again, the nursing home transition diversion participants, TBI, nursing home residents, assisted living program participants, and duals that did not require the community-based long-term care services is the final phase. So we're assuming this will go on track, but we're going to learn as we do it, and so the dates may move around a little bit as we get out into the 13, 14, 15 environment. So I tried to put a couple of thoughts together about how this all relates to the aging network. The aging network obviously is a big part of the long-term care system and big value part of the long-term care system. So I think any aging network provider is a viable subcontract to an MLTC plan. If you subcontract with Lombardi plans now, you should be contacting your managed long-term care plans and you're obviously a viable subcontractor. And then, but the key variable in that is that you must appropriately value your services, both from a cost side and from a efficiency side, and get the appropriate reimbursement from the plan for those services. So the bullet really says service must be appropriately valued both by the plan and the provider. So if you give a service, a home delivered meal service or social daycare, or some other type of long-term care services, which is key to keeping people in the most integrated setting, least restrictive setting, and meets the goals of the managed long-term care plan, you're a viable subcontractor, but don't contract with the managed long-term care unless you get the appropriate price to pay for the cost of that service. So again, we have many ways to communicate. We have an MLTC work group that emails come in on a daily basis, and those emails are sent to staff and myself, and we work with them and respond to questions. So if you have any specific questions about MLTC, please send an email to this email link. Again, I tell people to go to the MRT website as much as possible. The MRT number that you should be looking for is MRT number 90, and you'll see the work plan up on the MRT website and the deliverables that we have committed to the Medicaid director to meet. So there's a lot of information on there as well. So basically, what can you do now? What can you do now taking this information away? So what I ask every group is to send me or to staff, so send them to me, 5 regulatory or policy changes to make implementation of all these reforms easier. So basically, you've heard a lot of information, you've heard a lot of broad information, but as you go into a managed long-term care environment, are there things that we can do at the state level to help both providers and plans, increase efficiency and also help, obviously, clients meet their long-term care needs? So I asked people to send me 5 discrete things that we can do to help, both on, on the regulatory and policy side, and to make implementation easier. I also have everyone to stay engaged and active. These things are moving. There's a lot of moving parts in Medicaid redesign. It's a $53 billion healthcare enterprise that's run here from the health department when you count all funds. They are very complicated systems, and they change. They change at a moment's notice with different federal requirements, different state requirements, different laws that are passed. So stay engaged and active. Check the MRT website. Send email questions in. If you don't understand something, send email questions in or call on the phone or get some information. A lot of times we here in the health department think we're being clear, but oftentimes we are not being as clear as we should be. So no question is a silly question. Please send questions in or if you need additional information. And then I would work with Laura and your association to provide quality feedback. When I say quality feedback, I mean, hey, this policy doesn't work for the following reasons. Or there's an issue brewing which you should know about. So we're always looking for quality feedback on different things. So those are the things that the participants on this webinar and others can do. We look forward to working with you. Here's my contact information. My email is the best way to get a hold of me. My phone calls take a little bit longer to return, but I have a healthy addiction to my BlackBerry and iPad. So please feel free to email me at any point. And I asked, think creatively. It's a big change. But eliminating fee-for-service personal care in this state is a huge change. The program has been operational since 1980, and we are doing the best we can with obviously the ultimate goal of the family and the caregivers and the participant at the center of it all. So think creatively about how you can be part of this change. Stay informed and empowered. We want to hear from people. We want to hear what you think, what you're seeing on the ground, and also how we can be helpful. So that's the end of my slideshow. I assume I generated some questions, and I'll flick it back to Laura or the moderator to give me do some question and answer period.
Thank you so much, Mark.
Sure.
We do appreciate you sharing the details of mandatory managed long-term care. I also wanted to emphasize, you mentioned at the opening of the session that you started your career in aging by working for the Senate Aging Committee, which is, of course, how I met you. And I did want to emphasize to everybody on the phone that throughout his career, Mark has remained a great friend to aging, and he truly does understand the Aging Services Network. So we do very much appreciate you providing a lot of the information. And yes, we do have a lot of questions, and we have plenty of time for questions, so this is good. So keep your questions coming. I'm going to ask them of Mark, and even though some of these questions may have been addressed during your slideshow, Mark, you may want to expand upon them because obviously people did have some questions. So let me see. Here's one. How will we know when a county has enough capacity for transition to occur? Will timelines be posted on the MRT website, or will LDSS or local districts of social services be notified?
Yes, there'll be a communication plan that was set up as we go to other counties. You'll know well ahead of time that we're moving to an additional county. So we'll communicate both with the local social service district, as well as through the MRT website and other avenues as well.
Okay. Here's a question about, is the CDPAP included in home care services and covered, and does it have to move to managed care? And for those on the phone, CDPAP is Consumer Directed Personal Assistance Program.
Yes, and I'm glad that question was asked because I can provide additional information, supplemental information it's not in the slides. We also, as part of the MRT and part of the law that was passed last year and then amended again this year, was to require that all plans have the self-directed option available. So CDPAP or other consumer-directed options must be available for all managed long-term care plans and care coordination models. So we are big fans of self-direction here at the health department, and we want where appropriate, we want that those options to be available for persons that they're appropriate for. The CDPAP program is part of the personal care program, the way it's funded at the federal level. So it will be moving into managed long-term care. We delayed that for 3 months into September, from July to December, so that we could really do an education campaign and have the kinks worked out on the major program before we moved in the roughly about 10,000 people in CDPAP statewide. So again, New York City's first, and the CDPAP people in New York City will be enrolled in first, people already under plan. And then as we go upstate, where there are a lot of CDPAP people upstate, when their county personal care program is tagged to go in, they'll go in as well.
Okay, here's another CDPAP question. What requirements are you making for providers who are operating CDPAP programs, and is licensure a requirement?
So the question is, what are the requirements for CDPAP? We have a separate work group that's meeting as we speak on how to make self-direction available through managed long-term care plans. We have not decided whether licensure is required. Obviously, if you're doing home health care type services, you need to be licensed. However, CDPAP is exempt in some cases from Article 36 and set up as a separate model. So the real question is, are we going to require licensure? There was no change in the state law on CDPAP this year, besides the fact that they have to be part of the options, and we have not decided, and they're still weighing the options about whether managed care plans will require licensure for CDPAP.
Okay, thank you. Okay, will clients still be able to utilize private duty nursing services via nurses who have their own Medicaid number? If so, how will the person access these services, since clients will have to be signed up with an MLTC program?
Yes, that's a great question. Obviously, the private duty nursing benefit does not go away; it just moves into plan. So the private duty nurses should become part of the plan network of providers, and then those will be reimbursed through the capitated arrangement. So if you have a private duty nurse and you're happy with that nurse, and then you should join the plan that has that nurse in their network, and then you'll get services from the nurse, and the nurse will be paid by the managed long-term care plan instead of by the state directly fee for service. There should be no change to the service. It would just be a way the care is organized and financed.
Okay. Here's a different question. Where does New York Connects, or ADRC, which is Aging and Disability Resource Centers, fit into this model, and how are you fostering communication and cooperation between Medicaid services and all the non-medical community long-term care services that are essential to maintaining people long-term in the community?
Yeah, that's another great question. We have been working with Greg and Lori over at Office for the Aging for a long time. I think we had a recent meeting with the Medicaid director who comes from Wisconsin, who's a strong ADRC state, and we will be working together as we implement all these reforms. I think that the New York Connects program, has been around a long time, and I think will grow in this administration and be a vital part of the long-term care system.
Okay, if you can speak briefly about the status of the long-term home health care program.
Sure. So the long-term home health care program is a 1915C waiver program that's been operational for a long time, back in the late 70s, early 80s. It serves about 20 to 30,000 people on any given day. That's the enrollment in the program. That program will be going a dramatic change under the law that was passed last year. As we implement managed long-term care program, this managed long-term care rollout, the front door to that program will be closed as in the counties that we have managed long-term care capacity. So there won't be new enrollees in the program. There are still people under care in the program, so the waiver will survive. And there are also people under 21 on which the waiver will serve, the federal Lombardi program will serve. But the Lombardi program itself will look a lot different 3 years or 2 or 3 years from now than it does today. Obviously, the Lombardi providers are also certified home health agency providers, and they can be viable subcontractors to the managed long-term care plans. So we're going to try to make, there is a future for Lombardi providers and to be part of the networks of managed long-term care plans.
Thank you. Okay, back to CDPAP. As a user of CDPAP, will I be notified of the upcoming change by my LDSS caseworker, or will I receive something in the mail?
Probably both. You probably will see, we'll receive something in the mail about choosing a plan when that county goes to mandatory or to auto assignment, and then I'm sure the local districts will be in contact as well. I mean, we will work all avenues of communication as soon as we get federal approval on these changes.
Thank you. Okay, let me see. Scrolling through everything here. Has the state developed a plan or encouraged MLTC managed care organizations to reach out to AAAs to become subcontractors for the Aging Services Network? I think there's a follow-up here. If the AAA is not currently a subcontractor with MLTC plans, how can we identify who the appropriate contacts are to begin the discussions?
So we have on our DOH website the list of all the current plans, and we also have what's called an application tracker document, which tells the world what applications are in process of being developed. Obviously, we have a lot of information about the plans, and it shows which counties the plans are authorized to provide services in. We don't have a specific plan to say you must obviously contract with a AAA or AAA provider of services. But we had Greg come and speak to the managed long-term care or the managed care operational issues meeting, and we're strongly encourage plans to work with any provider in the community that does great services to deal with those services. So there's a couple different ways that you can look on the DOH website to get contact information, and then obviously check that'll be refreshed as we approve new managed long-term care plans. And then I would say, each county has long-term care councils that, that should be an agenda item to try to make sure that everyone's on the same page as far as what plans are in which counties and how to develop those relationships.
Thank you. Offices for the Aging across the state are usually the agency that people 60 and over turn to for assistance with enrollment in Medicare plans because of the HICAP program. How will a dual eligible plan enrollment work with the existing HICAP program?
Yeah, HICAP is a great resource. It kind of makes sense of this maze of requirements a lot of times, a maze of information. So HICAP will be part of all the different eligibility and enrollment initiatives that go on in the future. There'll be more detailed information available shortly as we get federal approval and work through the process. The other thing that's also happening here is this dual demonstration program that the federal government's been working with us on, and that is still in the formative stages of development, and HICAP will be part of that when that rolls out in 2013 and 2014.
Okay. A question about the enrollment brokers. How will that be selected? Will it be a competitive application, or what's the status of that?
Sure. We have a contract with Maximus, which is the state's enrollment broker, a long-term contract, and that contract was competitively bid a couple of years ago. So we're still in that contract term. Once that contract expires, we'll probably have to competitively bid that contract again. But Maximus is our enrollment broker, both on the mainstream and the managed long-term care side. They have extensive experience working as such. And right now they're our contractor. When that contract ends, before it ends, we'll be probably doing an RFP to procure either them or another contractor in the future.
Okay. What kind of consumer protections will there be, particularly the ability to appeal adverse decisions?
So the Medicaid program has a significant number of consumer protections. We are not taking any of them away. There is a fair hearing right in Medicaid and a continuing right. So those will be retained in the Medicaid program, as well as there'll be additional opportunities for consumers to appeal within their managed long-term care plan. There's different grievance and appeals procedures in plan, as well as the overriding Medicaid fair hearing right.
Okay, I know you talked earlier about the federal waiver, but someone is interested, I think, in a little more specificity, if there is any such thing from CMS. Is the federal waiver on track to be approved by July, is the exact question.
Yeah, we've been having actually every other day conversations with our partners, our federal partners, and there's nothing that leads us to believe that they're not going to approve this in time for the July 1 rollout. They are very interested in the details, and we've been talking to them every other day. But they've always indicated that the schedule that's been laid out is something that they anticipate approving.
Okay, next question. Transportation is an important community-based service. How will that service be accessed in long-term care managed care plans, especially as transportation is carved out from managed care in the MRT?
That's a good question. I'm not exactly sure how the transportation works because I know there is this other MRT carve-out plan. It is a benefit in MLTC, so it'll be in plan where appropriate, where it is. But so I will get back to you if you're Laura on exactly how that works with the other MRT proposal.
Thank you. There's a question about health homes. How does all of this fit within the context of the upcoming health homes?
So it's a good question. Actually, before the webinar, I was meeting with Greg Allen, who's our health home program lead, about that exact question. Health homes are really another strategy on care management that's specifically targeted persons with chronic illness, one or more chronic illnesses, and the dual eligibles in health homes cannot be excluded from health homes. So these two initiatives are going on at the same high profile at the same time in the health department, and we're working on trying to meld them so that we have consistent policy at the moment. I think the health homes and the managed long-term care programs will work in collaboration with each other. The key that the meeting earlier today is to make sure that we're not paying twice for care management, or that everyone knows exactly what the roles and responsibilities are between health homes and MLTC plans. So that's a work in progress, I would say, and it's a very good question.
Thank you. For those individuals who have not enrolled in MLTC program but need long-term skilled nursing care following hospitalization, how would that affect discharge planning and transitioning to higher levels of care?
So if a person is in need of a nursing home or skilled nursing home care, either on a rehab or a custodial basis, there's nothing in here that affects that. These are people, the initial efforts in this MRT 90 is for persons in need of home and community-based care in the community, obviously. So a person can be in MLTC and go to a nursing home. It's part of the benefit package. But if you go from hospital to nursing home, nothing that I just laid out here will affect that transition.
Okay. Can you speak about how duals with a spend down will pay their spend down to Medicaid or to the plan? Who will follow up for non-payment?
Right now, in the voluntary managed long-term care plan, the spend down works such that the MLTC, the managed long-term care plan, collects the amount. And there's an adjustment made on the rate setting system. So the managed long-term care plan is responsible for collecting the spend down amount. There are detailed procedures and policies about people from the non-payment of that, or they're not getting the information required. The way the spend down works, I've been told, is that you just have to accrue the cost. You don't necessarily pay the cost in order to meet the spend down amount. So we have about 45 to 50,000 people in MLTC. There are a significant spend down population. I've not heard any major barriers or problems in that issue, but the federal government also asked about that question. So we're looking at a more detailed analysis of how the spend down works.
Okay, has the state considered incorporating an aging services assessment component as part of the universal assessment tool?
Well, as I said, the universal assessment tool, it might be a good subject for another webinar, Laura, actually. But we've done a extensive review. It's the RAI tool out of it's R. I don't know what an acronym stands for, but I think if you Google search it, it's available to people to look at, and it assesses for all sorts of ADL needs and other type of needs. So it assesses by definition for services, to meet those needs. I'm not sure what an aging services assessment is it compared to what the UAS does, and so we will follow up with the association on that after the webinar.
Okay, and I should note at our upcoming Aging Concerns United conference, both Mark Kissinger is presenting a workshop and also Carla Williams on the Universal Assessment Tool. So anyone who's attending that conference can learn more, and if you haven't yet, you can go to our website and sign up. All right, a few more questions here. Will there be a way to identify individuals who are enrolled in Medicare and not Medicaid but may be dual eligible?
Well, yeah,
makes sense.
Yeah, we're working on that. I've met with a couple people about that issue. It's people that are Medicare enrollees and possible Medicaid enrollees is the question.
Yes, yes.
So we don't have a formal way to do that at the moment, but we've been talking about whether we can start getting those people enrolled into Medicaid as part of the overall Medicaid enrollment strategy.
Okay, somebody asked to speak a little bit more to the dual demonstration program that you mentioned earlier.
Sure. So the dual demonstration program is part of the Centers for Medicare and Medicaid Innovations. I also refer people back, sound like a broken record here, but refer people back to the MRT website. It's right on the MRT website. The second revision of that demonstration program. We have until Friday of this week to get in a final draft proposal, and then that proposal goes up for federal comment as well on the CMS or the Innovation Center website. Now, this initiative is part of the Affordable Care Act on the center, and all the information is available either on the CMS Innovation Center website or our MRT website. The goal really in our demonstration program, there's two prongs of it, actually 3 prongs of that demonstration. There's a capitated arrangement demonstration where we would move people that are in partially capitated programs into fully integrated plans, both Medicare and Medicaid, starting in January 2014. And then there's a managed fee-for-service operation piece of the demonstration, which is using the current health home strategy and putting a more Medicare focus on it. To allow for some gain sharing of Medicare savings back to the health homes. And then the third prong of our demonstration is a smaller demonstration on the OPWDD side. So there's some providers around the state that want to experiment with capitated arrangements on the OPWDD side. So there's a fully integrated demonstration program on the OPWD up to 10,000 members. So I would refer people to the Medicaid redesign website and look for the we have to send the final proposal to CMS by Friday. So that's actually taking a lot of my time this week, and we're just working on the final details on that at the moment.
Okay. We have a couple more questions here, so if anyone else has any questions, please do pose them. Otherwise, we will be wrapping up shortly. The next question, is any planning taking place to determine how those that are currently excluded will eventually be served?
Yes, at the beginning, as I said, the MRT the MRT action plan talks about moving in all the excluded groups into some sort of care management or managed care. So we were looking at a chart earlier this morning with trying to delineate all the different groups in Medicaid. There are certain groups like duals in nursing homes, for example, that the state law precludes us from moving them into managed long-term care or mainstream managed care. So we'll probably be talking to the legislature next year about changing that state law. But we are trying to delineate all the 5 million people that are in Medicaid at a point in time, which is depending on what data source you use, could be the 5 million moves around a little bit, and then trying to systematically move all those people into care management for all. So there's a lot of planning going on and a lot of timeline discussion with our federal partners. And then once we work out the plan will be publicized on the MRT website, and we'll start working with groups about specific timelines and program features and reimbursement models that have to be associated with each discrete population that moves into managed care.
Okay, we have had a few more questions come in. How will the MLTC changes affect the responsibility of providers to do good discharge planning before a patient is discharged?
We don't think it'll affect them at all. Actually, we think that is a bedrock requirement to be a healthcare provider in general, not even a Medicaid provider. So we don't think it'll affect it at all.
For a nursing home, you know what, I'm just reading this. This is similar to another one. Okay, I know you talked earlier about roles for area agencies on aging, and we've had a few questions about, maybe you can speak with a little bit more specificity about certain roles that AAAs could play as subcontractors to MLTC programs.
Sure. I mean, obviously there are things in the benefit package that the AAAs or their subcontractors are experts on. When you look at things like home-delivered meals and social daycare and other type of aging services, they are usually the expert in the community on that service. So they are logical subcontractors to MLTC plans as they come into different communities. There's not a predetermined notion or a preference at all, but there's you can logically associate services with the AAAs. The other part of the AAAs that can be used is obviously in their New York Connects or information referral function will have to be fully energized as communities do move into this managed long-term care environment. So I see the AAAs have a number of different roles, both as subcontractors and also as governments. They have the role to make sure that all the people are informed, and all the questions are answered as this change evolves.
Okay, there are a couple of questions about hospice, so I'm going to pull both of them up. Where does hospice fit into the MLTC initiative? And I'm scrolling up to the other question. Hospice provides very limited services in some counties, less than 2 hours a day of specialized nursing and or counseling. Why does this waiver exempt individuals?
So, obviously hospice works really well in most communities and has some issues in some other communities. It's an important service that's available both on the Medicare and the Medicaid side. There are detailed federal rules about hospice and about control of patients, and when a hospice takes over that they control the case, kind of how we've articulated it internally from a policy level. So we're still trying to figure out how hospice fits in with all these different arrangements, and also what kind of federal flexibility we have in hospice. For right now, we've kind of put them in the parking lot. We've decided that they're an important service that should be accessed still through fee-for-service. At some point, we'll try to move them into the managed care management rubric. But for right now, the hospice service has been carved out and remained fee-for-service on the Medicaid side. So there's still work to be done. We have to make sure we do it in a careful, planned way, and that we don't, inordinately affect hospice in a negative way. And there's a real concern that some of these moves could really decline the percentage of people in hospice services.
Will there be a standard process for determining how much long-term care services a beneficiary needs, or will plans be able to devise their own process?
The way the plan works right now is that they must do an assessment of the participant's needs within 30 days upon enrollment. And in the interim period, the current care plan stays if they're in a current personal care or current long-term care services on the fee-for-service side. Each plan must have obviously a care planning requirement and appropriately assess individuals. We're going to try to encourage the use of the SAM tool, the semi-assessment tool, abstract tool right now, and they've been moving to the UAS tool after that beta test is done and it's fully operational. So there will be a unified assessment tool that's used across the plans. As far as the services that they authorize or get, clearly the entitlement is to any Medicaid service, but a plan will work with the participant and the family on making sure that level of service is appropriate to meet the need.
Okay, I understand that Greg Olson does have some questions for you, Greg, so or for Mark. So Karen will unmute his screen and then he can ask questions. Are you there, Greg?
I am. You hear me?
Yes.
Awesome. Thanks, Laura. And thanks, Mark. Great presentation and Q&A. I just have a couple of questions. Some of the AAAs have mentioned to me and some others that they've been really aggressively pursued by the managed care organizations. It's kind of taken them back a bit. We think it's primarily due to them trying to get their paperwork and applications in order and meet your guys' timelines in their ability to show that they have capacity and the infrastructure to kind of move ahead and do the expansion. Does that sound reasonable?
Yeah, it definitely. I mean, we are starting to see a lot of activity as managed care plans figure out their business plan moving forward. Obviously, this is a movement of tens of thousands of people and billions of dollars, literally, into from fee-for-service to managed care. So there are a lot of activity going on in the different communities. So we would just encourage, obviously, any provider or any collaborator to make sure that they know what they're agreeing to or not agreeing to, and if they have any questions about their relationship, we're always available as well through the communication vehicles.
Okay, thanks. Is there any legal prohibition from an entity or an organization collecting the rates that a managed care organization may be paying a AAA for a particular service and sharing those rates with another AAA?
I have no idea. I could look into that. I mean, so the question really is more about are the rates protected information on the
Correct.
contract level?
Right.
I don't know. I can look into that.
Okay. And just one other question, because I think you've answered all and provided great information. There are a lot of services that the AAAs could potentially become a vendor for. Is there any prohibition from a managed care organization financing services that aren't necessarily covered in the benefit package if the area agency can show from their metrics that they are able to save, healthcare dollars or help keep people independent? Thinking of some of the things that the area agencies do, like the matter of balance and chronic disease self-management and some of the medication things. So is there any prohibition from the AAAs approaching the managed care organizations with services that are above and beyond what was listed on your slides as those services that must be covered?
No, obviously there's no prohibition on doing that. The key is to make the case that within the capitated amount that this investment in this type of service will ultimately save the system money. And so there are major opportunities for aging service providers to make those cases within the managed long-term care plans.
And your advice to a AAA would probably be, and as I heard you earlier, the role of the long-term care councils, but really being proactive in trying to build the relationships rather than, waiting to be approached, because there are timelines and so many moving pieces, and trying to foster and strengthen those partnerships are really something that, the AAAs can be proactive on.
Yep. Yeah, I would think proactive is definitely the way to go.
All right. Thanks, Mark.
Sure.
Okay, well, that concludes the list of our questions, and I once again wanted to thank Mark so much for spending some time with all of us. We did have close to 200 participants today, and we in particular appreciate the Q&A segment, because I think it gave people an opportunity to ask clarification questions, so we really do appreciate your time, Mark. We just have up on the screen some information about our upcoming conference that I mentioned earlier, because we are not only featuring a workshop from Mark, also from Carla Williams, and also one of our opening keynote presenters is Jason Helgerson, the Medicaid director. So you certainly can get many more answers to your questions at that event. We do welcome feedback from today's session, and you will receive an electronic survey immediately after the webinar ends. Please do fill it out, because we will use it in planning future webinars. And this now concludes today's webinar. Thank you.